Okay. Hey, good morning, everyone. Happy Monday. I hope we all survived that windy, crazy weather that we experienced yesterday. Some of us had some crazy high winds and temperature shifts. Welcome to our school nurse spring checkup. My name is Cindy McKinney, and I am the Assistant Director at Region 8 Education Service Center. And I am happy to have a statewide network. Region 8 had been doing this for quite a few years on our own. And last year we decided to expand it, and all of the service centers jumped on board. So, welcome and hello to my service center colleagues out there who are on the call. Some of us are joining virtually from our clinics. Some of us are in a space at a service center joining. And because of the miracles of Zoom, we're able to do it all. So I'm excited about what we're doing today and what we have to share with you. So I am going to, some of you are already welcoming yourself, introducing yourself in the chat. If you haven't already done that, please do so we can kind of say good morning to each other. I love that kind of aspect as well. We have a busy morning. You can see the agenda that we have set up for you today. And we are going to try to keep on our schedule and do the best we can to do that. I'm going to make sure everybody is muted so that we're able to all hear the call when we have our speakers on. And I'll do my best to monitor the chat as well if questions come up at any point. So without any further ado, I'm going to introduce our first speakers. Mute. There we go. I'm going to allow our first speakers to come on, and our first speakers are Jolene and Deb, who we all know Jolene perhaps, but I'll let her introduce herself. And we are Jolene, where are you?
I'm right here.
Yep, we can hear you. Do you have, let me stop my share screen and then I'll let you share your screen if you have
Okay,
slides that you want to share with the group.
I do. Can you all see those slides?
We sure can.
Okay, great. Well, good morning. My name's Jolene Burkale, and I'm the school nurse specialist at the Department of Education, and I want to welcome you to this conference. I too, like Cindy, am really excited to have all of you here and to have this as a statewide conference. For my part of the presentation, I'd like to review the sudden cardiac arrest law, and then I'm going to discuss some outbreaks, specifically the 20% absenteeism rule. And then I know that this conference is very fast paced and we have many great speakers. So I'm just going to jump in and get started. So first of all, I'd like to give you a little bit of a legislative update. Just to explain the process of how the legislation works is that bills are written by legislators and then they must pass through various committees in the House and then also in the Senate. If a bill passes through all the necessary committees, and it's at least four, they have to go at least through two in the House and two in the Senate. Ooh, I'm not sure what happened to that slide. Cindy, can you help me with, I see a lot of squiggles in my slides. I'm going to escape and then start sharing again. Okay, I'm not sure what happened there, but
That's all
we're gonna
right.
we're gonna go through a legislative update. Okay, so if the bills pass through, it will go two times through a House committee. And then if it passes through that, it will go to the Senate or vice versa. and then it must pass through at least two more committees to be signed by the governor. If it goes to the governor for a signature, then if he signs it, then it becomes Indiana law. Okay, once a bill becomes a law, it is assigned to a particular agency, such as any code starting with Title 20 would go to the Department of Education, or any law starting with Title 16 would go to the Department of Health. So if you see an Indiana code and it has numbers on it, the first number of it would tell what agency is responsible for that actual law. This agency is responsible for determining the guidance needed for the law, unless the responsibility is given to another agency through specific language written into the law. Sometimes they'll write a law and then say other people are responsible for pieces of it, and then that agency also helps. So the law that I really want to talk about today is the sudden cardiac arrest law. And it's because that law is the one that was the only one really that was changed this past legislative session, even though there was a lot of discussion, there were a lot of language in bills that took different parts of the legislation out, put it back in. There was a lot of moving pieces, but it ended up that this is really the main one that impacted school nurses. So, a little bit of history about the sudden cardiac arrest law is that it was a proposed bill in 2015, and that's when it became a law. It starts with Indiana Code 20. It's Indiana Code 2034-8, which means it came to the Department of Education for guidance or implementation. So it's been around for about the past 11 years, and through that time, it's going through quite a few revisions that we're going to review today. So since it started in 2015, it required coaches at that time. And then in 2021, band leaders were added to this section of the law, which says that coaches and band leaders need to provide information sheets to parents and students, that they need to receive a signed parent and student acknowledgement form back to them, that they need to remove students from practice or play if they're suspected of experiencing symptoms of sudden cardiac arrest, and they have to allow students to return to play, but only after they receive a verbal, then followed by a written permission from a parent. Another section of the law, again, requires coaches and band leaders. This one was not part of the original law. It was added in 2021. And then in 2023, it also added in drama and music leaders. Now, all of those categories of staff members have to complete a sudden cardiac arrest course. That was a part of the original in 2021. And then in 2023, like I said, drama and music leaders were then required to take a sudden cardiac arrest training course as well. And in 2025, they added two more informational steps to the law, which said that these staff members have to ensure that there's an operational AED present at each event, and that they have to inform all individuals who are coaching or providing leadership the location of those AEDs. Then again, this was in 2025, a new section that was added last year, and it required public, charter, and accredited non-public schools, which means just about every school, to develop a venue-specific emergency action plan for sudden cardiac arrest, and it had to include some of the elements recommended by the American Heart Association or any other nationally recognized program. And then they had to share the plan with the coach, marching band, drama, or music leaders, plus the students. And this was the responsibility of the schools. So this year, in 2026, they added one new sentence. So public, charter, and accredited non-public schools are still required to develop a venue-specific emergency action plan for sudden cardiac arrest, and they have to share the plan with the staff members and the students. But now it goes into a specific addition about that sudden cardiac arrest emergency action plan. It says that in that plan, schools must include the number and the location of the AEDs that are required for the events. So it's very specific, and it says in the plan, you have to, as a school, explain where each AED is and the number of them that are around your school, either inside or outside. It also added a new requirement for coaches, band, drama, and music leaders. It kept that they have to have a sudden cardiac arrest training course, and they kept that they are responsible for ensuring an AED is present, and they're informing the coaches and the students of the location of it. But now it says that it's their responsibility, these staff members, to not only ensure that it's present, but it has to be exactly as specified in that venue-specific emergency action plan, which now specifies the number and the location of all the AEDs in the school. So it gives some responsibilities to schools and some responsibilities to the staff member in charge of these extracurricular activities. So as the Department of Ed, these are the steps that we're really recommending that if schools follow, they're actually implementing and meeting all the requirements of the law. First is that they should create a cardiac emergency response team so that they have people that are trained and responsible for um, uh, administering or responding to the sudden cardiac arrest. The school needs to determine the number, the placement, the installation, and the maintenance of all the AEDs that are under their discretion. Also, they need to train the response team, and then there were specific staff members that are listed in the law. So they have to make sure that their coaches, marching band, drama, and music leaders are all trained. They have to develop a venue-specific emergency action plan. And in most of the materials, it's actually called a SERP plan, which is a cardiac emergency response plan. And they'd have to include the number and the location of their AEDs in their plans. They have to share the plan with each coach, marching band, drama, music leader, and students. They should integrate their local EMS into your plan so that the response is smooth from when the event occurs. Emergency personnel are summoned, and when they get there, that it's seamless transition between the school and the EMS. Conduct drills to practice your plan, and then annually review and evaluate your plan to make sure that it's still functional and works well for your school. So these SERP plans are quite extensive, and this is from the American Heart Association from their website. If you look through here, this is just about the SERP resources. They have other resources on their website, but you can see it's got checklists, reviewing your drills, evaluations. It's got PDFs, documents, and then if you look in the right-hand corner there, there is a link that you can download all of these through zip file so that you can have them and actually review and make sure that your SERP plan actually meets all of these requirements. There's another group called Project Adam, who's really quite wonderful as well. And it's formed at Riley Hospital for Children and led by a pediatric cardiologist. And you can see that this also has information about external AEDs that you can go and find more information about that, again, about the response team. And then here it has this cardiac emergency response plans. This is really the main part of the sudden cardiac arrest law is that you have the AEDs, you have staff trained, you have enough information to actually place the AEDs, you have a plan in place. And again, this has some information about templates and things that posters that you can post about the SERP. And it also has at the bottom a heart safe school training videos that it can train schools on how to manage their response plan. So both of these organizations, the American Heart Association and Project Adam, both provide the followings for schools. They provide resources and templates on their website. They have manuals that you can follow, and then you can actually call and contact them, and they have people that are available to assist you, either over the phone. They can come to your school, help you with how many AEDs you need, where should you place them, review your response plan, and have any additional suggestions or recommendations that you might need. So you find all of the information that I've just shared about the resources are on the Indiana Department's school health webpage. You can either click on this link, or if you just Google Department of Education, type in the search bar on that main webpage, health, it will take you to this webpage here, where it says at the top, the Department of Education School Health. And then it has all of these different sections. And if you scroll down to the bottom, these are all alphabetized. If you scroll down to sudden cardiac arrest, click on that, and all of these resources and links and information about this law can be found on that webpage. Okay, now that we talked about that law and explained a little bit about the history of it, what the old criteria and requirements that are still in existence are, and then the new ones that were added this last legislative session, I'd like to talk just a minute about disease outbreaks in schools, because this will then tie into all of the next couple of speakers when they talk about outbreaks and diseases and immunizations. So there's really two types of outbreaks that can occur in schools. First, there's one where there's a large number of students ill, and they could either have one or a variety of diseases. So they could have strep, norovirus, different types of influenza, any combination of all of those. When the absentee rate reaches 20%, that triggers some action in Indiana. Then the second type that other speakers are going to address today are students, or when students are ill with a particular one type of illness, and it's a vaccine preventable disease, such as there's an outbreak of pertussis or measles or mumps. And those don't have to meet a certain criteria of 20%. It's really what the case definition is for that. So when there's a 20% absentee level, the school nurse's role is the following. So they should monitor the illness and symptoms and gather information. They need to report that information to the administrator, and I would start when an absentee rate is higher than normal. So you could go to your school now and say, what's our normal absentee rate? A lot of schools are between 5 and 10% is normal every day. They have that amount of students absent. I know in schools, when we were talking about what do we set the level at when they made this law and rule, and we said, well, 10% could be normal for some. 15 really is an indicator that there's something going on. 20% really is an abnormally high level, and that's where we put the rate at. So be talking to your administrator if you see it's higher than your normal. If you're starting to creep up, see what you can do about that. Hand washing, mitigation steps to maybe lower or keep it from going to that 20%. When it does reach the 20%, the rule says that the school has to communicate with the local health department, and that's typically the public health nurse. And then they also have to report it to the Department of Ed. And that's a JOT form that has the link on that main website that I just showed you. There's another section in there besides sudden cardiac arrest. There's one on reports. You can click on that. And the major emphasis really is when there's a 20% absentee level, it's the main thing is to keep the sick students home and to make sure that you alert parents saying, here's the symptoms. If your student is at all ill, please keep them at home so that we slow down the progression and the transfer and exposure to other students, as the ill students should stay at home and not spread it to others. When you report it to the Department of Ed, you only count those students who are ill and physically unable to attend school, either in person or virtually. So even if your school has gone virtual, you can still count all those students in attendance if they're able to learn. If they call in sick saying they're too sick to even do virtual, or they're not there in person, those are the students that count, that are physically ill, and not other students that might be ill for other reasons. It's just the ill students that go into that 20%. You also calculate it and report it by individual school, not by school corporation. So even if your whole school corporation, if you have 4 schools and they're all over 20%, that's 4 individual reports, because those schools could reach it for different reasons. They could sustain that 20% for 4 or 5 days, where another school only has it for 2 days. So each day that any school in your corporation reaches that 20% absenteeism, that triggers a report for that school for that day. And reports should only be submitted for the day that they reach the 20% or greater, and not even if they're close. But if they're 20 or over, those are the days that the reports are submitted. There's also no percentage that dictates a school response, such as people will call me and say, okay, we reached 25%. Does that mean we must close a school? Or now we're at 30%. Does that change from being 21% absentee rate? And the answer is it's individually determined by the school and the health officer of the school of that county, and that there's no percentage that dictates this particular response. The school and the local department should collaborate on next steps depending on the type of illness causing their absenteeism. And it's really the local health officer's call, and they determine the best course of action alongside their stakeholders, such as administration from the school. And it's all based on the type of disease, the exposure level of students and staff, how many have really been exposed, the measures already taken, and the community spread. Is it in the community at large? Is it just isolated to one school? What are the diseases? How is it communicable? Is it airborne? Is it by shared airspace? Is it by touch? How is it how are other people exposed to it? So the options for the school is that they can remain open, they can revert to e-learning, or they can close the school. And that's all determined in collaboration with the school administration and the local health officer. If schools have questions about, once they've determined what their action is, they can contact the Indiana Department of Education Office of Accountability with any questions they have about if they close their school, how they make up days, or if they're allowed to request and are granted a waiver. Those are all items that can be discussed with the Office of Accountability. Then the other type of outbreak is the vaccine preventable type. And this is when of the vaccines that are usually required to attend school. It's usually not included in flu, that's usually in the 20%, but ones that are required for school attendance, those are usually required vaccine preventable diseases, and outbreaks of those are based on an official case definition of how many it requires to determine an outbreak, and that's all determined by the department or by the local health department and their state attendance officer. This is the conclusion of my part of the presentation. I tried to keep it brief because I know there's a lot of great presentations following me, so I wanted to keep to my time frame. The next presentation will review vaccine preventable outbreaks. Specifically, they're going to talk about measles. And in that case, one case usually constitutes an outbreak of measles. And so the next two speakers I'd like to introduce briefly, and then they can introduce themselves. It's Kelly White. She's the Infectious Disease Director at the Department of Health, and Megan Carlson, who is the Director of Health Services at IPS. So I'll now stop sharing my screen and turn it over to Kelly and Megan.
Thanks, Jolene.
Good morning. Can everybody hear me?
Yeah, we can hear you great, Kelly.
Great. Okay. I'm going to go first. So let me get sharing here. Okay, great. So good morning. So as Jolene said, I'm Kelly White. I'm the Director of Infectious Disease Epi and Prevention here at the Indiana Department of Health. So we're going to talk about measles, everybody's favorite topic. But I will say that a lot of the things that apply to measles will also apply to other vaccine preventable diseases and even some other diseases that we deal with. So some of these principles are going to be things that will be familiar or things that might be good and will prep you for many things, not just measles. So this is our kind of large wheel of things that happens when we have measles in a school. So our first step is to confirm cases. So this is really going to be done by the health department. It's usually a combination between your local health department and our team here at the state. So do our cases meet case definition, meaning are they lab confirmed? Do we have epi links? Because that's really important for measles, that we don't want to take all of this action unless we're sure that that initial person, whether it's a student or staff, has measles. Now, generally, the next step would be to confirm outbreak occurrence. But as Jolene said, for measles, one case is enough. So as soon as we check that blue box, we can kind of skip over this green box. But for other diseases, where we would be waiting to have a certain number of cases or just above an expected threshold, is where we would confirm our outbreak occurrence, which generally then has some public health actions, which is going to be in this bottom yellow. So there's a couple of different things that we can do. Obviously, you guys have probably heard of isolation, so putting the sick person away from others. Quarantine, so people that are exposed, putting them away from others in case they become sick. But for when we're talking about measles specifically, and some of our other VPDs, we're talking about exclusions, meaning it's not really the same as isolation and quarantine, but simply we're excluding those people from school. They cannot come to school or other activities, depending, but for the purposes of this talk, for school. Post-exposure prophylaxis. So after the person's been exposed, can we give them either medicine or, in this case, a dose of vaccine to get them some post-exposure prophylaxis, and hosting vaccine clinics, right? So this is not going to apply to all diseases, but definitely would apply to measles and some of our other vaccine preventable diseases. And then after we kind of take those first public health actions, hopefully we've stopped that transmission, that ongoing spread, but we're going to continue into doing our surveillance. So we're constantly doing passive surveillance, meaning we're waiting for healthcare providers and laboratories to report cases to us for measles and many other diseases. But when we have these outbreaks in the school, we will be working with you as school nurses to check in to make sure you've not heard of any other staff or students that have become ill, and do more active surveillance to reach out more proactively to check to see what's going on. Ongoing communication, of course, this kind of falls throughout all steps. But usually when we're talking about things like measles, we have to think about notifying our families, our parents, our staff. We have to determine whether or not we're going to notify the public. Is there going to be immediate involvement? Sometimes that happens whether we like it or not. So this is where usually you're going to work really closely with your school corporation, your local health department, and then IDOH, we can help support that in making sure that everybody's aware of what's going on and has the right information, but we're not causing panic, which I know can happen when we're talking about things like measles. So thinking about contact tracing in schools. So measles is an airborne virus. That means that it's much, much more infectious than a lot of our other diseases. And unfortunately, it really likes to hang out in the air. So about 2 hours after someone has left the area. So if I'm sitting here hanging out and I leave, that measles is going to be hanging out for about 2 hours. So anybody that comes into that area would be considered exposed and be what we call a contact. Now, when we think about a school, because of this, anytime we have a single case of measles in a school, whether that's a student or a staff, the entire school setting becomes an exposure. So that means that all of our students and all of our staff would be included when we're evaluating those exposures. And then we're taking the next step, which is going to be verifying immunity for exclusions, which I'll talk about on the next slide. The other thing to think about, so your whole school, also think about, does that person bus? Are there school buses involved, especially if maybe those are shared with other schools? Is that person involved in after or before school activities? We've worked on many outbreaks where we actually see more transition in some, or more transmission, in some of those after school activities. Basketball is one that haunts us a lot in the state here in Indiana, and sports, as I said. So those also have to be considered in addition to your regular, 9 to 3:30 school hours. So why is it important to get that list of folks that are considered contacts? So for measles specifically, and this is going to be different for other diseases, but for measles specifically, anyone that we can't verify has immunity has to be excluded. So this chart is a little bit, it's got a lot of detail. You do not need to memorize this, because if this happens in your school, we are going to help you with this. The local health department and us here at IDOH, we're going to help you with this. But what you should see here is essentially, if someone has been exposed, we have to make sure that they either have 2 doses of their MMR, they were born before 1957 in the United States, or they have immunity, lab evidence of immunity, or provider verified history of disease. All of those folks, we're still going to monitor them, but they can return to school and work. We're going to monitor from that 21 days, right? It can take up to 21 days after someone's exposed to show signs and symptoms of measles. And then, of course, if they develop any symptoms, not just that rash, but a fever, anything like that, we're going to immediately exclude and work for further testing to see if that, in fact, is measles. Now, that bottom bucket is going to be our probably the most work here. So anyone that does not fall into those 3 buckets above, so no evidence of immunity, they must be excluded from school until 21 days after the last rash onset date. So one thing to think about with this is if you have a case of measles, we kind of start that 21-day clock generally from the last time that they were exposed, maybe the last day in school. But if there are more cases and more exposures, that clock can reset. Probably doesn't happen in schools as often as it does in family groups, but that 21 days is from the last time that person was exposed. And then in certain cases, depending on the individual person that's exposed, we may administer post-exposure prophylaxis. But again, that would be in partnership with the local health department and their healthcare provider there. So big thing here is we need to make sure they have immunity and they fall in one of these first 3 boxes. If not, they're going to be excluded for 21 days approximately. So thinking about messaging. So if there is a confirmed case of measles, it really is recommended that there's a school-wide notification that goes out, right? This is not something to keep quiet. Everyone in that school is considered a contact. And this actually can help you because that can help you track down those folks that were there and do immunity verification if you don't already have that ready, which we'll talk about in a second. But that's for a confirmed case. So that's after you've heard from your local health department or us at IDOH that yes, this person in your school, student or staff, has confirmed measles and we're taking those actions. If there's a suspect case of measles, that school-wide notification is not yet recommended. So we're going to wait and see what do we think about this patient. Usually we're going to get testing that can be done through our state lab, through a private lab. However, depending on the situation, there may be a need to put out some communication, right? There's a lot of rumors. We know with social media in this day and age, it might be easier to get ahead of it. So we will work with you, our local health departments and us will work with you to determine what's going to make the most sense for your school group and your situation. We have lots of template letters that we can give you to help customize. And it's really up to you at the school and the local health department to work together to figure out what's going to make the most sense for that specific situation in your specific place. You guys know what your areas are. If you live in a rural area versus a more urban area, that may make a huge difference in how you do messaging. So things like that. But just something to keep in mind, that it's always nice to think ahead when it comes to communication. So a couple of notes to think about. So when I talked about exclusion criteria, this applies to students and staff. So it's not just your kiddos, it's your teachers, it's your cafeteria workers, it's your library folks, it's everybody. So you really, really need to think about, can you get those documents and get those lists and have that kind of knowledge of who is not have immunity ahead of time. Usually, the second bullet here is if we have folks without immunity, we can get them a dose of MMR. They usually can come back. And as I said earlier, those exclusion periods may be extended as new cases are identified. So that last piece we talked about, exclusion and vaccine clinics. So depending on what's going on in your school, your vaccination rates, how many cases there are, it may be a great time to do a vaccination clinic. So that's something that you're going to want to talk really closely with your local health department. IDOH can also support to see if that's really going to help in that case, or if it's something that maybe isn't necessary. So preparing for an outbreak. So what can you do now? Hopefully it'll never happen, but we know what the world is like. We know that we're seeing measles at highest levels that we've seen in a long time here in the US. So compiling documentation of that vaccination or immunity for all of your students and staff. Again, that's everybody in your building. Whatever you can do ahead of time is helpful because measles moves quick. Even though we have a 21-day period, we're talking like the first day that we know about a case and we've confirmed a case, we're going to be reaching out through our local health department partners and asking you to get us this information so we can get those folks that need to be excluded right away. So reviewing those records, having them on hand, building a relationship with your local health department. If you don't take anything out of this presentation, if you haven't been listening at all, it's Monday morning, maybe you're still sipping your coffee, not quite awake. Make sure you reach out and figure out who is your local health department, who's your public health nurse, your contact, maybe it's a school liaison. That's your person, because that's the person you're going to call when you find out that you have a case of measles, or maybe they're calling you. Or if you suspect that you have a case of measles, which is the next bullet point, you hear from a parent, you have a student that comes to your health office and you send them out to the hospital, something like that. We always appreciate if you think something's going on, give us a call at the local health department, give IDOH a call, but we generally say talk to your local health department first. We can help get ahead of it. It's always better to report ahead. So that's the kind of work you can do if you take nothing from this. Make sure you've got your local health department there on speed dial, you know that number. But if you can, really work to compile that documentation ahead of time for all of your students and all of your staff, because it's going to be really important. And the more you have that done ahead of time, the better that your school can keep going along. Those students can stay in class. Those teachers can keep on teaching if you've got their immunity lined up, and we know we don't have to exclude them. So with that, I will stop sharing here. And I will let Megan go next.
Thank you, Kelly. All right, you guys see that? Except
Yep, we can, Megan.
don't want that there. Okay. All right, so I am going to focus a little bit more on the prevention side. Kelly, a lot of what she said may be repetitive in here, but I'm going to kind of dig more into the details about how you as school nurses can prepare, and then in the event of an outbreak, it won't be such a disaster because you already know what you're doing. So this was already discussed by Kelly. We know that our schools are essentially cesspools, but declining vaccination rates are really impacting the vulnerability to outbreaks around our district. And we also know that along with learning loss, students also lose access to vital support services. So when we talk about excluding or quarantining or whatever it is from school, it really has an impact on a lot of our students in terms of access to the medical services we provide, access to therapy, access to food, access to just a safe environment. So it really is important that we do our best to make sure our kids stay in school whenever possible. So prevention, obviously increasing vaccination rates is one of the best things that we can do as school nurses. Having that high coverage in schools and even our surrounding communities is the most effective way to prevent measles. Those school-located vaccination clinics are really critical to improving immunization rates. So if you have partnerships in your community, like I would start doing them now, and I will continue offering regular vaccine clinics if that is an option for you, and then also providing ongoing measles education to families using whatever channels you have at your disposal, on your website, social media, emails, texts, automated calls, and then in multiple languages. We just sent out a letter to our families reminding them that measles is still out there. And if they're traveling for spring break, here's the hot places. Here is what to look for. Here's what to do if you think you have measles, and just making sure that we are consistently communicating with our families from a public health perspective, what's going on. And then again, the vaccination rate needs to be at least 95% to have that herd immunity to protect our most vulnerable. Another area of prevention that we did is we made sure that we did measles identification training for staff. This doesn't have to be in depth, but even for teachers or school administrators, definitely for your school nurses, just make sure, because for a lot of us, we've never seen measles before. So making sure that everyone really knows what to look for. We created these one-pagers that kind of gives you a timeline of what it looks like, and then an identification flow chart to just help people walk through, like, could this really be measles or is this something else? And I'm happy to share my email and all these resources with you as well. Monitoring measles cases, our health departments do a great job, but for me, I really wanted to monitor myself as well. So, the CDC has cases and outbreaks. If you're less comfortable with CDC for whatever reason, Johns Hopkins has a really great outbreak response. This was developed, if you remember their COVID tracking dashboard that they have, this is kind of the same thing. And you can see here how you can really drill down into your county and see what the rate's looking at. Is this something that's come into the state, or is this an outbreak occurring from cases inside the state? A measles emergency operations plan. So kind of the same thing with COVID. It's really important to have a plan in place. We prepare for tornadoes, we prepare for fire, but communicable disease planning is really not often in our plan, although it may be now because, again, COVID. And COVID really exposed those gaps in planning for school. So having a measles emergency outbreak plan can help you have a fast, coordinated, and consistent response and keeping your school operating to the best of its ability. And FEMA here has a really great guide for developing school emergency operations plans, and this can be adapted to any sort of emergency. So the before, when we did our emergency operations plan, we talked about what can you do now, and that was, making sure that you have isolation and quarantine protocols. Like if you have a suspected case that pops up during the school day, where are you going to put them? Who's going to be able to access that clinic? How are you going to clean and make sure that nobody else is impacted or walks into that clinic? What are your procedures for reporting cases? What are your communication protocols for family, staff, and the media, like Kelly said? And then what is your plan for continued school operations and support for excluded students? And again, this may not be something that you're doing, but sometimes we can help push principals or school administrators like, hey, we have to have this plan in place. And then guidelines for transportation. If you do have an outbreak, how are you going to get everybody home? What does that look like? And then again, guidelines for dismissal and school closures. Again, with the before, so we put together another one-pager, preparing for that rapid communication for confirmed measles. We have a bunch of templates that we put together. Again, I said identify that quarantine room, relocation plan, make sure that you have adequate PPE that's stocked and readily available. And then again, as Kelly mentioned, tracking your students now with missing MMR vaccines for quick reporting. And I would also send out information to those families, letting them know, just a reminder, hey, if we have a measles outbreak, this is what that looks like. If you change your mind or if you need help, here's how you can get the MMR vaccine. And then again, I can't stress enough, continuing to host those school-based vaccination clinics, targeting those high-risk students. So during, like Kelly said, you're going to coordinate with your local and state health departments to manage the outbreak, and then keeping your families informed. And again, this isn't something that the health department's going to tell you what to do. You can decide how you want to communicate it, but here's some of the things that we were including in our communication, how to screen at home for it, including symptoms and care resources, what are our current and future response measures looking like in our schools that will impact families, what resources are available for screening and vaccine access, and then what are our guidelines for if we were to have a closure, what does that look like? The after, reviewing and updating your policies and protocols after a measles outbreak ends is important. Looking at what worked well, what didn't, and then, assessing those barriers, gaps, challenges, and then deciding what necessary changes and improvements could be implemented. Decide what practices should be continued, what could be revised or discontinued, and then continue to identify additional community partnerships, any supplies or resources to strengthen your readiness for next time. And so further on the role of school health, school nurses, monitor for outbreaks and trends using those surveillance systems, promote the vaccine with those clinics. Any event, we try to have a vaccine clinic at back to school, at kindergarten roundup. If we have any athletic events, we try to take advantage of every opportunity. Educate staff and students on measles symptoms and transmission, support with those policies and procedures around exclusion, isolation, and return to school, assist with early case identification and referral, coordinate with public health, provide clear, timely communication during outbreaks, and then coordinate roles and responsibilities aligned with school guidelines and needs. And I have included a lot of toolkits and resources that are available from either the CDC, the AAP, or that Reams really has some really great resources on there. So thank you for your time. And I will put my email in the chat if anyone wants to get their hands on stuff that we've created.
Thank you, Megan. So appreciate all of your sharing. And the question has come up a couple times in the chat. We will be sharing the slide decks with you along with the recording of today. So don't feel like you have to take ravenous notes unless something really sticks out for you. So appreciate again all of our sharing this morning. So with that, we're leading into the talk of vaccine clinics. And before we do that, we want to talk a little bit about some of the confusion that is happening around vaccines. So we have Lisa Robertson here to kind of speak to that. So Lisa, are you on the call and ready to go?
I am. I am here and ready.
Thanks.
Okay, let me share my screen. Thank you for having me this morning. So let me change this to, there we go. So I'm Lisa Robertson. I'm the director of the Indiana Immunization Coalition. I have been in this role for about 13 years. So I'm going to, I have to always start out with pictures of my kiddos, and this is just from the very beginning. I've been using them as models for my social media, but also I think it's important when we're thinking about kind of vaccine hesitancy and how we're talking to parents. One of the most impactful things that I can say or that you can say as a nurse is the person that I care about most in this world, I make sure they're vaccinated. So both my kids have their entire HPV series. They get their flu and COVID every year. They have their meningitis B series. There's a picture of my husband in there getting his COVID shot. Like, one of the most important and impactful things that we can say is, I believe in this so much that I vaccinate the most important people in my life. So I made sure my parents had their RSV vaccine. So thinking about how you're sharing your messages around vaccines and just saying, I gave it to my own kids is one of the most powerful things you can say. So the mission of the coalition is to educate, advocate, be a statewide partner, and then offer direct service. So I put in here just a few slides about kind of where we're at in terms of vaccinations across the state. This is looking at that infant series. So this is really telling as we're starting, as we're looking at kids' entry into kindergarten. So at 3 years old, they should be totally done with all of their pediatric series. And we can see during COVID, it kind of dipped a little bit. We've started to come back up in 2025 at 65% of our kids by the age of 3 having a complete series. But I'm a little concerned to see what comes out in 2026. So in March of 2026, probably later this month, we'll get updated numbers. So I show these just to kind of give you guys a feel about where we are in the state in terms of vaccination rates. And then our adolescents, and this is that 13 to 18, so past that 6th grade mark, we're looking pretty good. Our MCV4 at 94%, tetanus at 95%. HPV, obviously, we have a ways to go. But our immunization rates, because of our school requirements, are pretty healthy. We are seeing these starting to drop as we look at the quarterly numbers. These numbers are starting to decline a bit. And if you don't, I think I have, yeah. If you don't know where to find this information, if you go to the IDOH immunization website, there's a data dashboards you can see right there towards the bottom of the screen. And in that, you'll find kind of the infant rates. There's school, you can look by your school district, by your county. There's adult rates. There's a lot of information about where we are in vaccinations in your community. So I hope that you're looking at this data because it's really, really interesting. So a little bit about kind of the HHS schedule that was released on January 5th. And what that looks like. So this was the schedule that was released in January by HHS Director Robert Kennedy. So it kind of changed the schedule into 3 different buckets. So there's the recommended for all children's bucket. So you can see that in the dark blue, and that includes things like DTaP, Tdap, pneumonia, Hib, polio, MMR, varicella, and HPV. And then moved over into recommended for high-risk groups are RSV, but that high risk is any child whose mother did not receive the vaccine during pregnancy. Hepatitis A, hepatitis B, and meningococcal were put into this certain high-risk group. And then the other category that was created was recommended based on shared clinical decision making. Rotavirus, this is where COVID and flu ended up, and then also hepatitis A, B, and meningitis again. So the thing that I always like to talk to all providers about is this shared clinical decision making category. I don't think there's anybody on this call who doesn't do shared clinical decision making for every vaccine, even the vaccines listed on recommended for all children vaccines. There's no time when we walk into a clinic or we walk into an office and we administer something to a child without talking to the parent about what we're doing. So every vaccine decision that's being made is based on shared clinical decision making. A parent can always refuse a vaccine. And so this schedule really just kind of sows confusion for patients and parents by kind of making these categories for no reason. There was no kind of evidence-based decision making on this. It was just HHS pulled the Denmark schedule and released it as the new childhood immunization schedule. So this is what the old schedule or the new schedule looks like. It has not been adopted by the ACIP, so the Advisory Committee for Immunization Practices. So the current schedule still looks like this. This is the AAP schedule. This is what all providers in the state of Indiana and most of the country are following, which is kind of the old ACIP schedule. Looks the same where everything is recommended. Hepatitis A and B are not shared clinical decision making. They are universally recommended. Meningitis is universally recommended. So how this applies to school nurses, because I know that there's a lot of questions about what will school immunization requirements look like in the 26-27 school year. And right now, the 26-27 school requirements are the same as they were this past year. They have not changed. We are hoping that they will not change. What we're waiting on is ACIP. So again, Advisory Committee on Immunization Practices. It's supposed to meet at the end of this week. So if that happens, and if they adopt the HHS schedule as the recommended childhood schedule, then it's possible our school requirements will change because it is very hard to make a required vaccine for a category listed as shared clinical decision or certain high-risk populations. So we're waiting on ACIP to meet. They're supposed to meet the 18th and 19th, so Wednesday and Thursday of this week. So they're very dysfunctional. I don't know if you've watched any of the madness that's happened. It's very dysfunctional. But if they were to pass this schedule, we would likely see changes. Now, I will keep everyone posted as I hear what goes on with ACIP. The only other kind of caveat to that is there is a court case, the AAP versus Robert F. Kennedy, that is looking to have an injunction that will not allow ACIP to meet and that will rescind the January 5th schedule. So that is being heard in a New York court. They are supposed to get kind of a judgment on those two things before ACIP meets on Wednesday. So either today or tomorrow, we will know if there is an injunction put on ACIP meeting and if this HHS schedule has been rescinded. All of that to say, there is a lot going on the federal policy level. It is very confusing. The coalition is putting out as much information as we can when we have it. But for right now, the response to any parents or administrators about school requirements for next year is that they are the same. They have not changed. If you go to IDOH website, it is still the 26-27 schedule, same as it was this year. We will keep you posted on the lawsuit and on the ACIP meeting because, yeah, it's a little crazy. So I wanted to just give you guys a few examples about, I think for us in this space where we live and breathe vaccines, we think about them a lot, we talk about them a lot. It's hard to understand all of the misinformation and why parents can be, can easily follow some misinformation because you think, oh, well, misinformation is easy to spot, right? It's scary. It tells you not to believe doctors. Like it's easy. So I wanted to show you just two quick examples of why it's hard sometimes to recognize misinformation. So I have two websites that are on this screen. One is the American College of Pediatricians. That's kind of on the top a little bit. And then the other one is the American Academy of Pediatrics. If you look at their logos, if you look at the way their websites are set up, they are very, very similar. So, and you know, American College of Pediatricians sounds like a legit organization. But if you kind of do a deep dive into their website, it is, they are anti-vaccine, they are anti-transgender care, they are for conversion therapy. There's a lot of what looks like good information on the website, but it is obviously not the American Academy of Pediatrics, which is what they're trying to mimic in the way they look. So it's, you know, the first time I read something, you know, that was posted by the American College of Pediatricians, I was like, what is this? Like, that seems legit. There are actually pediatricians that belong to this group. But until you really look at their documents, it's hard to understand what they stand for. So it is very difficult sometimes to navigate this space. So here's an example of just a good old Google search. So this is CDC ACIP, which is again that Advisory Committee for Immunization Practices, HPV vaccine recommendations. So if you searched that, click on this very first market watch. So the very first thing that comes up in news. This is what the article says. CDC Advisory Committee for Immunization Practices considers expanding recommendations for HPV vaccine to include 27 to 45-year-olds. So you can see this is an article from 2019. So this has been going on for a long time. Now, if you would see that byline with, you know, RFK now, it should hopefully give some people pause about the article itself. But in 2019, unless you really knew where he stood on vaccines, you probably wouldn't have been like a red flag for RFK's name in the byline of this article. So if you're reading through it, and we're just going to look at this very top box that says, the fact that during Gardasil's clinical trials, an extraordinary 49.5% of subjects receiving Gardasil reported serious medical conditions within 7 months of the start of the clinical trial. So if you just read that seems like a really scary statistic, right? Half of all of the subjects who received Gardasil reported a serious medical condition. So it looks legit. It's a clickable link, so you know there's a source. So if you were to click on that 49.5%, because it is a hyperlink, it takes you to an actual clinical review. So this is a good document. It's a good trial. It was based on the Gardasil trial. So this is legit, which again makes you a little concerned. Now, this is 464 pages long, so fun reading. But if you find that, you know, if you were to search for 49.5%, this is what it says in the actual research. The incident rate during the vaccination period in both treatment groups, 49.5% amongst Gardasil recipients and 49% of placebo recipients were similar. So basically it's saying samesies, right? 49.5% of the Gardasil recipients, 49% of the placebo recipients. There was no difference in reaction in either group. That's not what that article told us, right? That article said an extraordinary 49.5% of Gardasil recipients had an adverse effect. This is saying, so did the placebo group, it was the same. So if you look at what did they count as a new medical condition between the dose and 7 months, the most common new medical condition reported in subjects from day 1 through month 7 were headache and nasopharyngitis. So basically, people reported having a headache or a stuffy nose in the 7 months following a vaccine. I mean, how many of us haven't had a headache or a stuffy nose in the past week? But that was one of the new medical conditions that were reported in basically half of all recipients. So I use this just to show you that misinformation is hard to spot. And unless you have time over your lunch period where you want to do a deep dive into where these, hyperlinks are coming from, sometimes you'll click on things that will take you to nothing. It'll take you to a blank website. So it is not as easy as you would think to find and understand good information. So just some quick kind of talking points when you're talking to parents that, if they're asking questions, it doesn't mean that they're vaccine hesitant. It just means that they need additional reassurance. And remembering that you're both coming from the same place. So we have parents that come in who are, maybe they're doing one vaccine at a time, or they're not going to do HPV vaccine or flu vaccine. Remembering that they're trying to make the best decisions for their child. They want a happy and healthy child, just like you want a happy and healthy child. It's just not the same path to get there. So just reminding yourselves, like, they're not doing this because they want their child to get sick. They're doing it because they're afraid, because they don't have the right information, and that you both want the same thing. You both want a healthy child. So I'm not going to go over that. Just two quick slides on kind of some common things that we hear at the clinic is that, parents are worried about serious complications and not just brushing that off. So it's easy to say like, oh, vaccines are safe and effective, but there are side effects to getting vaccinated. And so being honest with parents about, there are likely to be some side effects, especially if we're talking about MMR and varicella or Tdap, where their arm's going to be red and swollen. MMR and varicella, they're more likely to have fever. So giving them honest answers about what, the most common reactions to vaccines are can really go a long way in easing their concerns. And then this is what we hear a lot with, I don't know how I got all the way here, with providers that don't do vaccines a lot is they're worried about the amount of vaccines you get at one time. But studies show that you can get up to 10,000 vaccines and your body would still be fine handling all of those antigens. In fact, kids today get far fewer antigens than most of us got when we were children. So this is just the chart that shows you over the years the amount of antigens that were in vaccines. And so when we were doing when we were doing whole cell pertussis, we were receiving 3,200 antigens to protect us from 5 different vaccine preventable diseases. In 2016, the antigens in vaccines for all of those diseases totaled 177. So you're exposed to more antigens every day. I mean, kids are licking, railing and that stuff. They are exposed all the time. This slide comes from Viral Truth, and I have a list of resources that are non-government. I'll share with you, and I'll share the slides with Cindy so she can send them out. But if you're hearing things like, the concern around aluminum is like the new thimerosal. So if you want to find ways to answer questions when parents say, oh, well, what about like the aluminum? I've heard there's aluminum in vaccines. There's aluminum in breast milk. There's aluminum in broccoli. So being able to relate it to things that make sense to parents, and by saying like, your child gets more aluminum in your breast milk or by eating broccoli than they do in this vaccine, again, helps them relate to like, what does this really mean? And Viral Truths has a lot of slides around these kind of quick conversations. This is the new talking point right now about placebo trials and vaccines not all being done using placebos. And the reason for that is it's unethical, right? So if you have a hepatitis B vaccine already and it does really good work, and you want to test a new hepatitis B vaccine, it's not ethical for you not to administer the current standard of care to kids and be like, oh, well, good luck. I hope you don't get hepatitis B. That's not ethical. So you test the new hepatitis B vaccine against the old hepatitis B vaccine because ethics, right? Same thing with HPV when they were trying to test for head and neck cancers in men. They couldn't say, oh, well, we're not going to give you the HPV vaccine And, hopefully you don't get anal or penile cancer because we want to see if it protects you against throat cancer. It's not ethical. So there are good reasons why we don't do all vaccine studies against a placebo trial. So I won't go through all of this because I want to make sure I don't go over on my time, and I think I'm close. Yes. So here's a list of the resources. Again, those viraltruths.org. It's a great resource. Let's Get Real About Vaccines is a great new resource. And again, I'll share this with everyone so that you can look through these and you can share them with your families as well. And let me unshare my slides.
Thank you, Lisa. That was great. It was a perfect segue into our next topic. And before we take a break, I will hopefully we'll have some time for questions. There's one question in the chat. So we'll hopefully the panel can stay on before we break and answer some questions. But the final piece of this discussion is around clinics. So how do we set up vaccine clinics in our communities, in our schools? So Sarah, I saw that you had jumped on as a call. Are you ready to go? Let's see if Sarah. Okay. Well, while we're waiting for Sarah, there is one question that came up in the chat for Jolene. And that was about Jolene, about the school day absentee for illness. The question was, if the absentee rate is for a school day is 19.5, do we round that up to 20% and report it?
Hi, can you hear me okay?
Uh-huh.
Yes, I would round it up because it's close enough, it would trigger enough of a response. And so again, if you're monitoring it and if it jumps to 19.5 immediately, round it up to 20. But even if it's, you start and you're monitoring it, like I said, kind of look at what's abnormal for your school system. And if it gets to 15, then it gets to 17, then it's at 19.5, I would round it up. And if it's anything 19.5 or above, count it as 20% and start the process of reporting it to the Department of Health and to the or to your local health department and to the Department of Education. If there's any other questions, you can put them in the chat, and I'm sure any of the people that were here would try to answer them.
But let me the date. Sorry, I had a quick issue. All right. Let's see here. I'm not sure that Sarah is on the call, but Sarah, are you here?
I am. I moved to another room so we wouldn't have interference.
Okay, great, perfect. Okay, so I'm going to let you introduce your panel. Let me share your slides. Let's see here. Okay. Can everybody see those? Oops. Here we are. Sarah, are you still with us?
I am. Can you hear me?
Yep. And the slide.
Right. Good. And you can go on to the next slide. Thanks.
All right. Let's see here. Hold on here. Too many things. Let me drag it here. And
Let's just talk about that. Good morning, everyone. I am also with the coalition, and we're so glad you could join us today for today's panel discussion on why, when, and how to host a vaccine clinic at your school. School-based clinics play a powerful role in supporting student health and increasing access for families. But as many of you know, organizing a clinic comes with a lot of moving parts. Planning logistics, coordinating with partners, communicating with families, and sometimes navigating unexpected challenges along the way. Today, we're fortunate to hear from 3 experienced school nurses who have successfully hosted vaccine clinics in their own school communities. Our panelists have organized clinics during the school day, after school hours, and a variety of different school settings. They represent a private school, a large school corporation, as well as a smaller district. They'll share their experiences, the obstacles they encountered, and the practical strategies they use to overcome them. We encourage this to be an interactive conversation. As the discussion is happening, please feel free to drop your questions into the chat box. Cindy, if you want to go ahead and take those as we're going, our panelists will answer them in real time if they can, and if we don't get to them, we can grab them during the Q&A portion. We also know that many of you on the call today bring valuable experiences to the table in this aspect. If you've hosted a clinic before, have tips, ideas, strategies that worked well, please also share them, because your suggestions may help another school nurse who is thinking about planning their first clinic, or even a nurse who tried a clinic before it wasn't successful and they want to go on and try another one. Now it's my pleasure to introduce our three panelists. Please join me in welcoming Sandy, Cody, and Kara, who will be sharing their insights and experiences with us today. Sandy, let's start with your story.
Hi, my name is Sandy Burnett. I'm the Director of Nursing with Noblesville Schools, and we started hosting vaccine clinics with the Immunization Coalition shortly after COVID. So I think we've been doing it for about 5 to 6 years. And for us, it was access. We needed a resource for our students that were underinsured or not insured at all, where they could get vaccines at a reasonable price or reasonable cost, or as if anyone's hosted with them, know they can access them for free. We needed something that would accommodate our working parents. Our health department has a great clinic program for immunizations, but they all take place during the school day. And I had a lot of parents who needed something in those after school hours that they could take their student after work. And so we started hosting them. We do them right after school from 3 to 6 o'clock in the evening. And we've had a great response from our parents showing up, getting their vaccines. And another positive for using the coalition that I love is that it's hosted right here in our community. We typically host it at one of our schools that's kind of the center of our community. If I have families that walk and can work on transportation. And so I feel like the location is a really important part too. The part that we bring it into our school really helps our families. So the other piece for getting buy-in from my admin is it was real easy to convince them for after school because we weren't taking up learning time. We did, in fact, several years ago, try to host a clinic within the school day, and we honestly didn't get much of a response. Parents were a little bit leery of us doing it without them being present. And so this has really, really gone over well in our community.
Thanks, Sandy. Cody, how about you?
Unmute. Shoot. Oh, there we go. Can you hear me? Okay. My reasons are very similar to Sandy's. We have a lot of working parents, and we actually do ours during the school day, and I found that we get better response doing that. I'll just serve as a runner. I have a whole list of all the kids that have been signed up, and our secretary in the main office helps the parents by signing them up. We are very much a Spanish-speaking school. So we do have a translator, which is our secretary, that would assist parents with signing up for the clinic. And I will basically take that list, go to the classroom, bring the kids to a setup location. We usually do it in the gym. We're doing one actually coming up April 30th. We'll set up in the gym with our tables. The coalition comes in. We do the vaccines. We walk the kids back to class, and everybody's done before the day is over. And our parents really like it because they don't have to take that time off from work. A lot of them are struggling with missing time, especially when you're calling for a child that has to go home sick. A lot of times parents are having difficulty getting coverage for work. I think that's really all. Administration was on board with it. We started doing our in-school clinics before COVID. And we are a Catholic institution, so we did have a little bit of pushback once COVID happened and then the COVID vaccines, but it was just more of like educating our priest that was here on board with our district that, the COVID vaccine was optional, wasn't something we were forcing.
Thanks, Cody. Kara. Is Kara on?
I don't know. Everyone's in who requested access. Oh, she's having difficulties. Yeah.
Okay,
So
I do have a question. Can I ask one question?
yes.
Cody, maybe it's more for you. During the clinic school days, do you have problems with the kids with the parents not around? I mean, that's sometimes a concern.
Actually, no, I find that the kids do better without parents present. We've had parents show up, and there's a lot more tears when mom and dad are present versus the teacher just kind of having maybe the littles, because we go to 3-year-olds, sit in their lap, they get their little vaccine, and then they're usually fine because you guys offer the lollipops, and that goes a long way. The lollipops and the stickers are a fan favorite, and that by the time they're walking back to class, they're fine. No more tears.
So for this one's for either of you. When you did your first clinic, was it super successful? Was it 5 people that showed up? Like we hear a lot of times that we've only, seen a few people, but my message is always it takes a little bit to get people interested, engaged, and trustful of the process. So what were your thoughts on those?
I was not in this
I
role when we initially started them, so I can't vouch for kind of where we started. But I do know that I have a lot of hesitancy with signing up. So pre-registration does not go well in my district. So I'm always not quite sure how it's going to go over. But I have found that typically they do show up, even though they don't pre-register or whatever.
think for ours, when we first started the first clinic I did, I maybe had like 30 show up. And then once the families kind of figured out that they can also come, because a lot of times parents will sign up and then the whole family outside of just the students here will show up too. And then we've actually done somewhere up in like 80, 90 people at one clinic session. And I did see a question. Somebody had asked how often we do them. I usually try to do mine in the beginning of the school year to kind of hit everybody in the whole school. And then again, I will focus at the end of the school year. And that focus is mostly going to be our preschool, pre-K, kinder, and the 5th graders that are going to be doing their 6th grade.
Yeah, and I'll add to that. I usually do 2 in the spring to catch those grades coming in, and then I do 3 kind of back to school to catch new move-ins and then those kiddos that didn't make it in the spring.
That's great. So Cody, you mentioned Spanish speaking families, and I know Sandy has that same demographic as well. Is there anything you do to help prepare those families? I think Kara's on too.
Hi,
So
yeah,
one
can
of
you
you
hear
could-
me now? I don't have the video, but I think do you hear me?
I
Yep.
can.
You can? You can hear the audio?
Yep.
Yes.
Oh, cool. Cool. Yeah, I'm on. I don't know where to begin now.
Well, that's okay. Actually, Kara, we were just talking about Spanish speaking families and how you get them to get it interested, signed up, and show up for the vaccine clinic.
Yeah, so we actually do have a very high Spanish speaking population. We have a lot of undocumented students here, and the families are actually scared to go to the doctor to get the immunizations. We have a Spanish liaison who, when I go through the immunizations, sometimes we don't even have immunization records for the students. And she is very good at explaining the process and then the importance to have the vaccinations. And there's quite a few times we have to start the series over, and the family's happy to do that just to have their children safe. They just need the understanding that it can be done here. It's not, no one's coming to do anything to take them. They're scared a lot of times, so it works out very well.
I know, Sandy, you've done after school programs but you've also done a summer event. So like way outside of school hours. Can you kind of describe how that went?
Yeah, so we have a large multilingual population, and so we very quickly learned that getting them to register for school, get immunizations, things like that were hard for that population. So our district created, we call it a multilingual picnic. It happens the week before school starts, and they have technology set up at our local park for families to come and re-register their children for the next school year. We have the Immunization Coalition come and we give shots. We have a picnic lunch, and then they also have back to school supplies for the students. So we generally have a very good turnout at that event. It's very fun and just takes place in our local park.
Sandy, does anyone else have anything they want to talk about? And were there any questions in the chat?
Yeah, there would, let me see. I'm scrolling through specific for you all. There was a comment that about using super shot clinics to host a satellite clinic. So I don't know if anybody wants to speak to that, but that might be another easy way to get a clinic going.
Yeah, so that's a great point. So how do we find these people to do the clinics? One, I would start with your local health department. See if they can come be on site for you. If they don't, they usually have someone in their area. Like if you're in Northeast Indiana, Super Shots is a great organization to have that do. There are several state organizations statewide. The coalition does that. The Department of Health does that. In the Indianapolis area, there's the Franciscan Health, there's School Nurse Direct. There's a lot of people that, and I will drop my email in the chat box too. And if you need help finding someone in your area, we would be happy to make that connection for you.
Great. Someone just asked if maybe, I think this was Sandy who was speaking to the picnic. Could you go over the picnic again?
Yeah, so it's just an event that happens that week prior to school starting. We actually usually host it on a Friday night, and it brings our multilingual families to the park for their kids to play. But we have our technology team there set up to do re-registration for school, as well as the coalition typically comes and gives any needed back to school immunizations, or as Cody had mentioned earlier, we have a lot of families that the mom and dad will get their shots too. And we give out free school supplies, and we usually have kind of a picnic lunch, and it's just a fun night in the community, but also meets the needs of the students.
Thanks. Back up through the chat, just so, because we have a couple minutes before we break. There is a question, and this could go to anyone on the panel on the whole morning, perhaps. Is there a resource that gives the number of cases for each individual illness that qualifies as an outbreak?
Hi, I can answer that. That there is the Indiana Communicable Disease Guide for Schools. It's posted on the Department of Health and the Department of Ed's website. It's updated every 3 years, 3 to 5 years. The most recent one is from 2023. And at the very back of it, at the end, there, in the table of contents, it has different conditions, and then it has a vaccine preventable section. And in there where it says, it lists different topics. How is it transmitted? What is the exclusion? And what determines an outbreak? And so it does list all the different diseases and the criteria for what determines an outbreak. And it's called the Indiana Communicable Disease Guide for Schools, and it's from the Department of Health. And I can find the link and put it in the chat.
Thanks. Teachers. I think some people are responding to questions in the chat, which is fantastic. Thank you so much. Helping each other out. I love that. Here's a question. Well, yeah, Lisa, do you want to talk about the remote registry function in Chirp, Michigan?
Yeah.
Great.
Sure. So I was just putting in there, I don't know if all school nurses are aware about the remote registry function in CHIRP. So if you're looking for a student, so primarily we see students from like Ohio, Illinois, Michigan, Kentucky, Florida, probably the most common that we see. So in CHIRP, if you go into CHIRP, you find the student. The thing about remote registry is they have to have a demographics page. So if they don't have a demographics page, you have to create one. But once they have a demographics page on the left under patient, there's a remote registry function. So if you click on that, you can query. It's Alaska, Arizona, DC, Florida, Illinois, Indiana, Kentucky, Louisiana, Mississippi, Missouri, Michigan, Ohio, Puerto Rico, South Dakota, Tennessee, Washington, West Virginia, and Wyoming. You can query those state registries and then import automatically that record into your student's record. So you don't have to manually enter it. Like I said, we use this a lot in Florida. School nurses have access to this. They just opened up that access, I would say within the last 6 months. If you don't have access, make sure you check in with CHIRP because they did turn it on for all school nurses. But it is a great way to import those records without having to then go in and manually enter everything. So I'd be happy to do a walkthrough with anybody. If you just send me an email, I'm happy to jump on a call.
I saw a lot of happy faces when you said that, Lisa. So I think you hit on something that is really valuable to nurses. So okay, I want to thank Jolene, Kelly, Megan, Lisa, Sarah, Cody, Sandy, and Kara for our morning filled with information, updates on all the hot topics right now. And we so appreciate your time. And if you want to stay on, please stay on for as long as you wish, or put things in the chat, emails, all that. I'll also send all of this to everyone too. So I'll send you the link to the recording, the slide decks, and then emails of the presenters. So you'll have it all in one-stop shop. So, okay, let's take a quick break. We'll come back if we can at maybe 10:32. That gives us 5 minutes. So take a bio break, and then we're going to come back with Meg Friesen, who's going to talk a little bit about mental health in the clinic. So I'll see you in 5. Okay, we're gonna start in about 1 minute. Meg, do you have a screen you want to share?
Nope,
Okay, cool.
that's not good for my mental health.
Then let's not do it.
We're just going to be super interactive.
I love it. Good. That'll be awesome. Okay. All right. It is 10:32. I'm gonna let Meg take over. There is when we come back, we'll make sure we get some other questions answered in the chat about even things that happened today earlier. But let's go ahead, and I'd like to introduce Meg Friesen. And Meg is kind of my partner in crime. She's been with me since the first. She's the origin of this. So if you want to say this is a fabulous experience and you love it, then thank Meg because she brought it to me and we made it happen. But I'm so thankful for her. And one of her passions is mental health. And so I'm going to let Meg spend a little time with us because we know we've got those kiddos that come to us and there's more than just physical things happening. So thank you, Meg, for always sharing your expertise.
Thank you. Thanks, Cindy. Welcome, everybody. It's good to see so many people here. Yeah, like Cindy said, we kind of dreamt this up maybe 10 years ago, and it's amazing to see how big it's grown. So I love that. I am going to talk about mental health today. And as I introduce myself, I would love for people to just throw in the chat what it is that you do to get through your day as a school nurse or a school health liaison. What helps your mental health? So if you have any things that you do during the day, this is an honest, vulnerable place. I see some of you laughing. If it's like screaming into like a pillow on the side, whatever it is that you do to get through mental health, your day, your mental health, keeping it good. McDonald's Diet Coke. I love it. Okay, keep those coming as I introduce myself. What do you do to get through your day? So I am the Director of Behavioral Health and Wellness with Huntington County Schools. And I started off as a school nurse. For the last 9 years, I was the corporation nurse of our school district. And during my time as the corporation nurse, I had always known that mental health was what I was passionate about. And so I went back to school to get my psychiatric mental health nurse practitioner degree. And when I finished getting my degree, I, talked to the school system. I said, I would really like to stay here and specifically work with students as a nurse, but specifically work with mental health. And so we created this position. And my job is to work on 3 things. So mental health specifically, and sometimes that means one-on-one or meeting with students in groups, suicide prevention, and substance abuse prevention. So working with kids who are currently using substances and doing some prevention work as well. So all of those things kind of are what I do on a daily basis. And I just wanted to talk about what is it like when we have students that are coming to the clinics with mental health challenges. And I just want to look, I love talking to the guidance counselor. That's a friend, laughing, complaining to the secretary. Amen for that. We love our secretaries. Taking a walk, caffeine, music, prayer, all of those are amazing things to keep you going. And so as I keep talking about this, I do want to say that as a school nurse, you have to try your best to be the most regulated version of yourself in order to do your job every day. So keeping these mental health dailies in mind is super important. But when we have kids come to the clinic and they're coming for whatever, a stomach ache, a fever, vomiting, anything like that, our kids are walking in the door, and some of our kids are coming with diagnoses like anxiety or depression, ADHD, autism, disruptive mood dysregulation disorder, oppositional defiance disorder, all of these different diagnoses. And some kids are coming with all of these symptoms, but without a diagnosis yet, right? So sometimes we know what's walking in the door, and sometimes it's just like a whole bunch of symptoms that could actually be depression or could be anxiety. And some of these kids that we see that come with a lot of these mental health challenges, sometimes we label them as frequent flyers. But a couple years ago, I heard at a conference, somebody said, let's stop with the frequent flyers and let's call these kids constant connectors. And that really changed the way that I looked at kids that were coming to the clinic on a regular basis. If somebody's constantly trying to connect with another adult in the school, what does that mean? And we know that all behavior is communication. So, what is that child trying to communicate to me? And so I tried to start to change my mindset. Instead of being frustrated every time so and so came to the clinic, I wanted to get curious. So, what does it mean to get curious every time that that student comes to the clinic? And I wanted to show you kind of like a simple way that you can implement mental health into what you're doing on a daily basis. So if you have Post-it notes somewhere at your desk, I want you to grab 4 Post-it notes. And if you don't have any Post-it notes, that's okay. You can just kind of take notes as we go. But my dream after this presentation is that everybody would come back to their school and they would have a Post-it note that has a triangle on it. Because I want to teach you a little bit about how this triangle can be kind of a reminder to you of bringing mental health into your clinic. So if you've drawn a triangle on a Post-it note, or if you just draw it on a piece of paper, we're going to label the 3 sides of this triangle, okay? So the bottom triangle, the bottom of your triangle here, I want you to write the word people. And then on either side of the triangle, I want you to write the word places. And on the other side of the triangle, I want you to write the word practices. So when you're all done, your triangle will have 3 labels on it: people, places, and practices. So one of the things that I said that I do is suicide prevention. And I run clubs within our school called Hope Clubs. And we have High Hopes, which is our high school club. And then we have 2 middle schools in my district, and we have Hope in the middle. And the way that this triangle works is it's the top of an arrow, right? So for Hope in the middle, we have like, this is our logo, like we have an arrow like that. And then the word hope is in the center. And then for High Hopes, we just have up arrows. But this triangle is the key to everything that we do. And if you know this triangle, then you can take this and use it with your students. So first off, when we think of people, so you have somebody come into your office and they are struggling, and it's really important that you know the people in their lives and they know the people that are the support system in their lives. So I always start with all of my students that I meet asking them who lives in their home. And this is a really, really big deal to know who lives in somebody's home. And sometimes you have to like get a diagram out to be like, well, my mom lives with this guy, but he's not my dad, but he's been my dad since I was 1, and like all of these things. So you want to find out what's going on with bio parents, who's living in the home, and who do they consider their support person. So that's the first step, is finding out who the people are in this student's life. So if they are going to be constant connectors and they are going to be somebody that's constantly coming to your clinic, that you'll have like a little thought like, oh yeah, I remember that this kid is super close to their mom, or this kid is not super close to their mom. And every time that they come down to the clinic, they don't want me to, bother mom or call mom because mom's sleeping because she works 3rd shift. So really being in touch with the people is important for all of your kids, but especially those kids that are struggling with mental health. Then you want to know from that kid and I usually put up my hand and I say like, who are the 5 people that are your biggest support system? Now, this is something that in elementary school, counselors usually do this with kids. Like they say, okay, everybody, let's trace your hand and let's write in each finger who are the 5 people that are your support system. And in elementary school, I think this is a really easy thing to do because kids are all about like, oh, I've got grandma and grandpa and mom and dad. There's just like I think they feel a lot of support. But I wish that we did this same exercise with kids as they went into middle school and into high school, to show you that having 5 people in your life, having a support system, and friends totally count, right? They can be one of the people in your life, is so, so important for our mental health. because at the end of the day, if we need to reach out to somebody, we need to know who these people in our lives are. And then I sometimes talk to them if they're having trouble coming up with those 5 people. Who are the people at the school right here that you could reach out to? So we talk about school counselors. We talk about, like, I'm the school nurse. Do you know that I'm a resource, like somebody that you can reach out to? Not every period of the day, but a lot of times, right? So, and then we talk about administration and how administration um, can be like scary to some kids, but that they're really here because they love kids and they want to help. Then we also talk about people like your bus driver. Are you really close to them? Are you close to the librarian? Do you have a good relationship with the person who works in the lunchroom? All of these different people that are, not specifically their teachers. But I always ask, like, who's your favorite teacher? If you had a secret, who would you tell? Would you tell that to, this teacher? So we talk about all the different people at the school. And then we talk about people that I call like school adjunct people. So these might be like youth pastors, it might be coaches, skills coaches, anybody in the community that for that student they would go to. So then, depending on how your brain works, I like to keep little flashcards of kids that are my frequent flyers or constant connectors. And I keep like a little card of that kid so that I'm not going to forget later all the different things that I just gathered. But I always do people first. Who are the people that are your support for your mental health? So then, second, we talk about practices and places. So I love this because when I first kind of thought of this idea of places, I was thinking of all the different counseling centers that were in our community. I was thinking of the emergency room because you can go there for acute issues with mental health. But then when I started talking to kids about places, all of them were like, oh, I have like a play fort in the backyard, or my living room, like there's a space on the couch that I really like to sit, and it's like really cozy because it's in the corner and I have this special blanket. So when I started to share this people, places, and practices with kids, all of the places were these places that they felt soft and warm and cozy and safe, usually within their house, but sometimes even within the school. And for some students, that place of safety is the school clinic. And so we know that our job is to get them, loved and taken care of and gotten back to the classroom. But for a lot of kids, that cot, in the back, of your office is one of those places of safety. So the second thing after you've gone through who are the people that support your mental health, you want to talk about who are the places or what are the places that support your mental health. So in this, I also ask if students are going to therapy, like do they see somebody on a regular basis? And if so, is that once a week, once every other week, once a month? And how do they get along with that therapist? Whatever issues are going on at school, do they talk about school issues, or do they only talk about like home and history issues? Because sometimes then they could be seeing like a counselor at the school that could help them a little bit more with what they're struggling with at school. Okay. So do they have a skills coach? Do they have a therapist? Do they have a psychologist? Anybody else that they see outside of school? And then I don't know how your schools go, but our schools, it's very easy as a school nurse to make a referral to a mental health clinic within the community. And if you don't do those, then making sure that the counselor does make a referral so that there is a place that that student can go if they need additional counseling or additional help during the school day or after school. So that's places. And then your third one is practices. So I would love if every school nurse would have 2 or 3 practices that were in their back pocket that they would use when kids came down, if they're feeling really anxious or if they're feeling really depressed, that these are practices that you feel comfortable using with students. But before you ever suggest any sort of practice for a student, it's really important to ask them what works well for them. Like, so I'm noticing, Gracie, that you are having trouble with your breathing right now. Is there anything that you ever use or you have learned that helps you with your breathing? And let's say she's going to say square breathing. And let's say your favorite thing is triangle breathing. It's not really helpful for you to suggest triangle breathing to her when she knows square breathing inside and out. So we always ask kids, like, what is it that helps you? What are your go-to coping skills or go-to practices that help you to calm down? Or if someone's feeling sad, you can go down the same route. Is there anything that you do that ever brings you more joy into your day? And remember, crying is a great coping skill for being sad. So giving students the space to just be able to cry and then come back and talk it through. So once you've identified what their practices are, they might be really good at just taking those practices and running with them, and they just needed a safe space to do those practices. But if they are like, I have nothing, like I'm melting in front of you, I need you to give me some sort of advice, or I need you to give me some sort of practice. It's great for you to have some sort of practice that you like. And you can look up, a million different practices online, whether it's breathing activities or things to calm students when they're anxious. But another great thing is to really look at yourself and be vulnerable with what it is that you do if you're feeling really anxious. And as long as it's school appropriate, then you could share that with the kids. This is what I do, and this really helps me when I need to calm down. Or when I'm really sad, I try this. Have you ever tried that? So being vulnerable with your own mental health and saying that you do have sad days, you do have anxious days, and let's work on this together. And I know that as a school nurse, you might have like 5 different kids lined up at your door. And so you might not always be able to sit down and go through a practice with a student. And you might need to say, let me see if the school counselor is available for you to go and talk with her or him. But it's really great as a school nurse to know that you have the power to help students with their mental health. And this is a simple way to think it through with people, places, and practices. So what I'd love for you to do is you have your triangle, but I'd love for you to have, another Post-it note that says people on it, another one that says practices on it, and another one that says places on it. And as a school nurse, you should be aware of all the places in your community that you can refer students to. So in our community, for example, we have Bowen Health, we have Renovate Counseling, we just have a new counseling center that just came in called Blue River Counseling. So I made sure that I've reached out to each one of those people, and I know the referral phone number. I could talk to a parent, talk to them through the referral process. I know how to do referrals. But again, if that's something that your school counselor does at your school, you could pass that on as a referral, making sure to say, I met with this student today and I really feel like they're struggling with their mental health. They don't have any diagnoses to speak of right now, but I feel like I've seen her 3 times in the past month, and it's all been for anxiety related to, testing, or anxiety related to her 7th period teacher, or anxiety related to eating lunch around other kids. And so you can be that connector so that the counselor can go ahead and set them up with somebody else, another place outside of the school system. So that's just kind of something that I wanted to give to you, that triangle, that idea of people, places, and practices. And I would love to answer any questions if you have them. And I know this is a very small amount of time, so we can go to the next presenter. But I put my information to the chat, my name and my email, and I'll put it back in the chat right now again. But if anybody ever has any questions about mental health and school nursing, I would love to be a resource for you.
Thank you, Meg. Does anyone have a question right now that they want to either come off mic and talk about or post in the chat? I think those are great. I love the triangle concept. I'm actually going to share that with some primary counselors that I'm meeting with later this week. So that's awesome. Okay. Thank you. Thanks so much, Meg. All right, we are ready to talk. Okay, so you're like, well, how did this schedule come about? Well, I met with a group of all of these presenters, key people in the community, and we kind of went through some things and talked about what the needs are, what kind of needs are bubbling up among school nurses. And so, in addition to all of the things that we've talked about this morning that are pretty obvious, and mental health, which we all know is also a big, always important issue for you all. There were a couple of other things that came up, including training health assistants, how to get into the Moodle site for resources. And then this one, again, later on, may not apply to all of you, but we are experiencing some challenges with toilet training, students coming in kindergarten not being toilet trained. So we felt like that was a high enough demand issue that we spent some time on that. So I'm going to invite Deb and Jolene back into the conversation, and they're going to talk a little bit about training health assistants and the use of Moodles, and then there'll be a little panel discussion about the toilet training protocol. So Deb, are you on and ready to go?
I'm on, and I don't really have anything planned. I don't know if Jolene does, but we have Kelsey Rockstro who's going to present on her process at her school. And I saw that she was on earlier, so hopefully she's still on
Yes.
and kind of ready to go. Thank you, Kelsey.
Hi, how are you?
I'll let you introduce yourself.
Awesome. Well, I'm going to share my screen as well. Can you guys see it?
Yeah. Yep, it's coming up. There it is.
Awesome. Well, my name is Kelsey. I am the health service coordinator for Elkhart Community Schools up in Northern Indiana. And I'm going to be talking about the training health assistants. I know that this has been something that has been kind of a hard topic for our district. And so over the past 2 years, we've kind of been tweaking, and I think hopefully we finally have something that's going to stick a little bit, and hopefully it'll help you guys out a little bit as well. This is the exact presentation that I present to all my secretaries at their back to school meeting. And I also go through it with all of my principals so that there's always a backup in case the secretaries choose that they don't want to be one, or if somebody like that is absent, because we know, especially this time of year, that we have lots of absent people. So I'm just going to click through these. So this is just the table of contents. I always like to give my people like a rough overview of everything that we're doing. So I go over, why we want to train people, how to give medications, any emergency type issues such as like asthma or anaphylaxis, seizures, if there's just a rough overview of diabetes. And then also go over things like the common complaints, like your common headaches and stomach aches, earaches, and kind of things that you may see a student come in for. And then when do you send kids home? Because ultimately, they're like, oh, well, this kid's been in here several times, or this kid, do they want to go home? Is it something I should send them home? Do I not send them home? And so it's just kind of like a little bit of a guideline on how to do that. And then I'm going to briefly touch on field trip delegation as well. So again, I just say our goal is always to have a fully staffed nursing team, but that's not always possible. And so it's important for us to train and do a universal training to ensure that the students are safe and cared for, even in the absence of a nurse. And by leading a foundational training and then having the schools address individual needs, we can promote the continuity of care and consistency of our practices. I always love this quote of coming together is the beginning and keeping together is progress, but working together is success. So working all together as a team. I know that I may be a nurse and you may be a secretary, but we're all in it for the safety and health of a student. And that's what our ultimate goal is. So then I go through kind of the medication administration and our check-in process. So every school in our district is required to have a sub-binder. The sub-binder is kind of like a guide for whoever's stepping in as the nurse. So whether it be another nurse or a UAP, which would be an unlicensed assistive personnel, or an administrator, it kind of gives a snapshot of the daily routines, any papers that may be needed, etc. It also includes a medication schedule, including the name, the medication doses, and the times. I always like to go through the 5 rights of medication, making sure we're always checking that we're giving the right student the right medication, the right dose at the right time, and the right route. And I think that that's important just to make sure, because I know that we all know in the middle of the day, it gets pretty busy. And especially if this is not your normal job, you're just filling in, taking those extra steps to make sure that our students are safe. This is our medication administration kind of checklist, what we do. So if a parent brings in medication, what do they do if a parent brings it in? And I always tell them, we need to make sure there's a medication authorization form signed, and that, if a kid just brings it in, we can't just give it to them, believing the first grader is supposed to be taking this. And making sure that if a medication is brought in, to follow this procedure, and we go through that check-in process. We also make sure, it sounds silly, but making sure that if you are stepping in for the nurse, to make sure that the nurse knows this medication was brought in. You want it to be locked in a safe location, but also letting the nurse know, hey, Jimmy brought in more medication, or Susie is starting this medication. We checked it in and it's here, so that they can put it on their sheets and all their in their programs as well. This next form just kind of goes out. Like I said, this is specific for our district, but I go through exactly what the forms look like. So this is the part that needs to be filled out by the parent. This is what this part is saying, and this needs to be signed by a guardian, letting them know that they need to bring in the refills, and that a student can't bring them in. And then we always go through an inventory checklist, letting them know, hey, this is how many pills mom is dropping off. This is how many pills we counted together, and then they both sign. On here, I have that the nurse signs it, but I always tell my UAPs, if you want to sign it, and then again, once the nurse comes back, you guys can check it again and sign it. And I always say this isn't to scare anybody. It's just mainly it's that extra check. It's to protect them. It's to protect you. Next, I go through all of the ways that medications can be given. So oral medications, making sure, again, that we're checking that it's the right name of the student, it's the right medication, the right dose, verifying the bottle with that authorization form. We always keep our authorization forms with our medicine right beside it, so we can always double check, always see what's going on. Place the medication directly into the student's hand, or if it's a liquid medication, putting it straight into their mouth. We always encourage that we do not pre-dose medications. It's just not good practice, and it's a way to increase mistakes or give wrong medicine to wrong students. So just encouraging that. I know it's busy during the day, and I appreciate your helping, but just to make sure that everybody is safe and everyone's getting their right medicine. And then we do have a document that is given to them in their sub-binder, where they can document it. So normally I will have our nurses or our administrators, whoever's in charge of the medication, they will pre-put on the student's name and medication, and then whoever's filling in will be able to sign off on that, as well as put the time of the medication that it was given. That way, when the nurse comes back, they can see the log, they can see what was given and who was given or who was absent, so that their inventory numbers aren't off. After that, I go through, again, all of the emergency checkpoints. So if a kid has asthma, like what do we do if a kid has asthma? And that's just kind of going through, asthma, the signs and symptoms of asthma. If somebody comes in with shortness of breath or difficulty breathing, wheezing, chest tightness, coughing, also going through then how to use the inhaler. So I know a lot of people are like, oh, you just puff it. And unfortunately, that's not always the best way to get the medicine in. So to be able to teach them, put the end of the inhaler in and to push it and make sure they inhale and hold it. I always play with my elementary school kids. Hold it until you can't hold it anymore. And then let that breath out, and then wait for about a minute holding it, or waiting if there are more than one puff. Afterwards, the students rinse with water, and then they are free to go back to class. If they are in the middle of an asthma attack, something where they need this as a rescue inhaler, I always have them stay in the office for a little bit longer just to make sure that that rescue medication does sit in, it does help, it does relieve them. Next, anaphylaxis. There are a lot of different anaphylaxis medications out there and ways to see it. It comes in different ways. You can have people that, turn blue and stop breathing. You have people that hives that just start itching. It's all over. So I always go over the wide range of different types of things that they can see with anaphylaxis, and then when to administer an EpiPen or IUV or Neffy. So I always go through the anaphylaxis, and in my training, I always have trainers available, something that they can feel, that they can touch, that they can practice. I feel like more people feel more comfortable using and being able to feel and see than just somebody who's talking to them and telling them. So I always go over, again, EpiPen administration, which is the blue to the sky, orange to the thigh. And then the IUV, which I have found to love if you're going to do an injectable, because once you pull it out, it starts talking to you. It tells you exactly what you need to do. Same thing, you're pulling off that guard, pushing it against the thigh, and holding it for 2 seconds. You'll hear that click. And then the newest one that has come out is our Neffy, and I have found that staff is loving having this available because it's much easier for them to use a nasal spray instead of an injectable, and they're much more comfortable doing that. And I don't blame them one bit, to be honest. So I know that I personally, for our district, we have reached out to Neffy. Neffy was fabulous to work with. I've linked it at the bottom of how you can get free Neffy for your schools, just like we used to get the EpiPens. They were quick, they were efficient. It was a fabulous program to work with, and I cannot advertise that enough. But again, I go over how to use that and everything. Then I go through seizures. I know seizures can be scary. Even as a nurse, for me, it's one of those helpless things, there's only so much you can do. And I validate them as it may be scary, but these are the things that we need to know. So any student that has seizures, I always encourage them to have their seizure plans close by, to have them in a binder. Again, for our school system, we put them in the sub binder, so they're there, they're ready, and they're available. I also have a copy of them with any emergency medication. So if the student has Diastat or Valtoco, I also have it folded and rubber band to there as well, so that they know it's right there. Again, easy for them to do it as possible. If no plan is available, I encourage them to call 911. Again, I understand and recognize that they are not medical professionals. They're not going to know the ins and outs and tricks and what to look for. And if there's no plan, I just encourage to call 911 and then call parents. This is another form. This is from the Epilepsy Foundation. I always print this and I laminate it and I have it hanging in the office. I also have it hanging or put in the sub binder, and then that way everybody is aware of it. Any teachers that have seizure kids, I also have this available. But again, things to do, make sure you time it, laying them on their side, making sure that they are safe. And then it lets you know when to call 911 as well. I then go through the Diastat administration, which I know is we're kind of veering away from that, but some kids still do have it. So I do go through this. I know it's scary. I know it's something that you don't want to do, but I always put it in the perspective of this is a kiddo's life, and this is a life or death situation if you're having to do this. So ultimately, making sure that keep the kid private, give them privacy, make sure we have somewhere for other kids to go. But then again, I also have this in the sub binder ready to go in case anybody would need it. And then Valtoco, again, just like Neffy, it's a nasal thing that teachers are just teachers, staff, anybody that's helping in the health office, they are much more comfortable with this. So I do go over that as well. And then moving forward to diabetes, diabetics aren't in every building. They're not in every school. But the ones that do, it can also be very scary. And again, having somebody that has no medical background or doesn't really know, it can be very scary to have to manage. And you think diabetes of managing highs, managing lows, and giving insulin and all this stuff. So I tell everybody that any diabetic student that comes to us has to have a diabetic management plan. They have to have this before coming to school. We have to know what's going on. With that being said, we can, just because a school nurse is there does not mean that we can send the kid home. Oh, there's no nurse here today. Sorry, kid, you got to go home. That's not something that we can do. So I do train multiple people in the schools for this reason. I go over the fact that there's multiple ways now to check blood sugar. You're not always having to poke a finger. Some kids may have continuous glucose monitors. Some kids have pumps that give their insulin. Some have pens that you can click and then you would have to give an injection. But regardless of the way, I always tell my staff, always go to the building first. So if you have a nurse in the building, they're the ones to do that. And if you don't have a nurse in the building, reach out to the parent. The parent is going to be the best advocate for that child. They're going to be able to help walk you through because this is their daily life. So like I said, reaching out for those specifics, because not every UAP, not every principal is going to have a diabetic. Again, the common complaints I go through, like for headaches, did you eat today? Have you been drinking water? When did it start? Do parents know at home? These are just, again, simple little prompts to help kind of guide people. So they're just not just like, okay, just go lay down. But like maybe the kid hasn't eaten today and they just need a snack to get through. Or maybe they have this sore throat and you're like, okay, try, keep drinking water. Do you have this congestion? Have you had it? How long has it lasted? And just asking a couple questions, again, to help guide you in that right direction. Another one is concussions. This has come up more and more and more, I feel like, over the years. And again, people are very conscious of, oh my gosh, they hit their head. Do they have a concussion? I always tell my trainers that I'm training, there should be a form that I put in the subbinder. It is from the CDC. It's going to be on the next slide, to check the student initially, check them after 15 minutes, check it after 13 minutes. If they have no symptoms, they are feeling fine, they're acting fine, I always joke, if they're acting like a fool, then they're probably good. Like they're jumping on your cot, they're ready to go back to class, they're good. They can return. I always copy the next sheet and then I send it home with the kids so that parents are aware and that they can see any danger signs in case anything comes up later. If they do have symptoms, I always say send them home. Just send them home, get them checked out by a provider for further evaluation. I'd always rather be safe than sorry. But no matter what the outcome, whether you're sending them back to class, whether you're not, always call home. Again, because these things can show up later. And so making sure that we're covering ourselves, just let them know, hey, Susie hit her head today. She's all good. She's acting good now. I'm sending home a paper. And that way you can know if any of these other signs come up, go find further or go seek further medical attention. So this is the sheet. Again, it comes straight from the CDC. I love this sheet because I feel like it's very concise. I mean, it's very easy just to check if you need to, and then sign at the bottom. So it's, again, very self-explanatory. It lets us know if we sent the kid back to class, if they're going home, if they need to be seen, and then any comments from us. I always have this nice little when to as well. Again, anyone for a fever, 2 bouts of diarrhea, the yucky eyes, vomiting, rashes that are open and oozing, and then those concussion symptoms. I always tell them, sometimes, you have your kids that are like, oh, I bumped my head and I have a headache. You're like, okay, I'm going to call your parent. I'm going to let them know, but they're acting fine. So you send them back. But if anybody is showing 2 or more symptoms, even if you think they're faking it, I always send them home. Again, rather be safe than sorry. And then I know I'm out of time, but I'm going to quickly touch base on field trips because I know, and then like we talked about before, any exceptions would be the communicable diseases if they say that you don't have to exclude, or if the vomiting and diarrhea is due to a medical diagnosis that this is a constant and they have a doctor's note to back that up. Field trip delegation, and this is going to be super quick. I always just go through because they don't need to know the whole entire this whole entire presentation. They don't need to go through all of this. They may not have a kid with X, Y, or Z. So I always have my teachers notify their staff 2 weeks before a field trip. They should know well before 2 weeks that they're going to have a field trip. So the nurses should be able to know to run things through. Again, go through that check-in, check-out of medication. They're going to check out the medication if they have any medications to give to students during the field trip. I go through, if they have oral medications, I just go through oral medications. If they have inhalers, I go through that. If they don't have anybody with an inhaler, if they don't have anybody with seizure medications or diabetics, I don't go over that information. It's not pertinent to them, and I only give them the information that they need that's pertinent to them. We always send one pill. We don't send the whole bottle. Send it with their name and exactly what it would have on the bottle, the name, the dose, and what time they need to take it. And then there's always a spot on the envelope where they can sign and put the time so that we're aware. If we need to send a liquid bottle, we do, but knowing that they also have to check that back in once they come back. Again, training those UAPs on just the medication administration and any emergency situations that would be student specific. So if they have asthma or allergies, seizures, etc. Documentation of that administration, and then going through an emergency plan. These are when an emergency. So if a kid were to have their first allergic reaction to a bee sting on a field trip, what do you do? And then who we're calling, when you're calling the nurse, when you call admin, and when you call parents. And that would be all district, per your district. And then if you have any questions, there's my email address. You can reach out to me. This is also has my office phone number. Like I said, I always give that out to all of my admin and teachers in case they need to reach out for any reason.
Elsie, wow.
I talked a lot real fast.
Well, no, you could, there's a teacher pay teachers website where you put things out there and then you could do a nurses pay nurses and do something else. It's such great information. We do have a couple of questions in the chat. We'll just go ahead and get to them right now. So,
okay.
Neffy is free via a program from School Health. Okay, that was maybe a question. Thank you, someone, for answering that. Mm-hmm. There was a question about if we send one pill or piece of in an envelope, isn't that dispensing? That's what they were taught. I think we're talking about the field trip.
Yeah. I don't know. Does Deb or Jolene have anything to say regarding that or how
to handle that?
Considered?
I never really found a great way to handle that when I was a school nurse, other than sending the whole bottle and then you risk the not getting it back or losing them or taking too many or so. I mean, that's a quandary that we've had to deal with in our profession for quite a while. And if Jolene has an answer, I don't know that she does. That's something we could do some more research on and try to figure out. But that is one of the problems that goes with field trips for sure.
Mm-hmm. Mm-hmm. Another question for Kelsey. For students who are unable to give themselves an injection for their diabetes, do you require safety pen needles for safety reasons?
We do not. We do a pretty extensive training, and luckily we have been lucky in the sense that we usually have at least one person in the building that has diabetes, that has had somebody with diabetes, or myself. So for instance, we have one school that nobody is comfortable giving it. And so I will go over there, and if they need a pen, I will inject. And or if I'm not available, we use our nursing, anybody within our district, any other school. So I could say, hey, I need you to run over to this school and administer this. That's been a hard one for us, honestly. And we have definitely had this in the past before I was in this position. This is something that had come up prior. And that they were just sending kids home because nobody wanted to give it. Nobody was available to give it. And we can't do that. And so I know that I have looked through the Indiana School Nurse Manual, and I know that they have also mentioned stuff about finding an admin, reaching out to admin, finding somebody, and then just doing the training through there. But safety needles or anything, no, a lot of the times it's just pens.
Yeah. We did have an answer to that quandary about the pill during a couple of people put in the chat. The pharmacies will give an extra empty bottle with a label on it for free, and then just have parents bring the empty bottle, and then you just send one pill in it. So that seems to be a workaround. And that's kind of what it looks like several people in the chat have added. So thanks. What else? Two people. Okay. Yeah, there's a lot of options if you want to read through in the chat for that quandary. Let's see here. I feel like I'm scrolling. Yep. I think, does the state standing order? Okay. We're getting questions answered. I feel like this has been so great, Kelsey. Thank you for sharing
thank
your
you.
slides. And we'll, if you're willing to share the slide deck with me, in a way
sure.
that, thank you so much. I will share that out with everyone, so they
Definitely.
can use it. Oh, appreciate it so much, Kelsey.
Awesome. Thank you so much.
Uh-huh. All right. So we are down to almost the end of our time, but we're going to talk a little bit about toilet training protocols. Again, this was kind of one of those hot button topics that has come up in conversation. And so Deb is going to lead the charge with that discussion, along with some other updates.
Sure. Thank you so much. Well, thank you, Kelsey. That was awesome. I kind of put Kelsey on the spot a week or so ago and asked her to share what she talked about in our member chat a couple of weeks ago. So very, very thorough and much appreciated. And thanks, Cindy, too, for inviting everybody that spoke today. I think all the topics have been really great. So I know this topic doesn't probably apply to everybody that's on this call, but it has something that I've gotten a lot of questions on. School nurses around the country through our NASN listserv are talking about, so it's not unique to Indiana. But it is a big issue with students coming to school either untrained or losing those skills after they begin their school attendance. And of course, the goal is to support students to achieve greater independence as much as possible, to foster inclusion in a supportive learning environment. And the big question is often who's responsible for the tasks of assisting the student who's been incontinent at school. But first, these messages. So this is a slide from last year's conference. It's our annual conference. And watch for more information on our website and in our member listserv. And I know Jolene will send out some information as well. It will be November 9th and 10th, which is a Monday and Tuesday again this year, mostly because of the schedule at the hotel. And it's at Embassy Suites and Conference Center, once again in Noblesville, Indiana. I know many of you have attended, many of you every year. So we will have an early bird rate this year if you register before September 1st. So watch for more information about that to come out. Our big highlight this year will be a case study and mock hearing before a fake board of nursing, that we will go through the whole process and pick members from the audience to be on the board of nursing and make a decision about the case. And you will recognize it as something that could or has happened to you in your practice. So look forward to that being really interesting. Also, we have an upcoming member chat for our members only on April 16th. It's from 1:30 to 2:30 Eastern Standard Time. This is a picture of our conference committee from last year with our logo and banner in the back. Some of you will recognize this. So watch for more information about that and the Zoom link. We always welcome new and returning members. And we've started a members only tab on our website with individual health plan templates and other helpful school nurse policy and procedure information, just as a member benefit for those that do decide to join us. And then just a little plug for the School Health Network Conference, which is coming up this summer. Many of you attend that. I know it's once again at the Embassy Suites in Plainfield. and it's free again this year. The 15th is actually a Monday, and that's a pre-conference day. And they have a full day plan for that day as well. That's kind of turned into their third conference day. So I know they're doing Stop the Bleed. I can't remember what else they're doing that day, but they do give CEUs for free, and they have breakout sessions scheduled for every time slot that have a topic of interest for school nurses this year. She tried to kind of keep that separate so you could go to the ones that you really want to see. I will be there exhibiting and I'm representing school nurses and the association. So watch for registration and more information. There is a link already on the homepage of inasn.org, our webpage. So that's it for the commercials. So considerations for incontinence at school. I'm going to go through this fairly quickly because I do have someone who's going to present on their policy that they have. I thought that's always interesting to see somebody else that has a policy that you could use as a template if you want to. So basically, every child develops at their own pace, and you can't refuse school entrance because they're not toilet trained. So you do have to take into consideration their developmental level, potential health concerns, and any physical or cognitive disabilities. So the way to go about it is to rule out any health issues first, and then you can go on to investigating potential disabilities. What often happens is a child may be trained when they get into school, but then the stresses of school and they regress. So nurses are the only staff member that can be required to actually be involved with the diaper training or with the diaper changing process. But obviously, as you all know, it doesn't take a nurse to provide this. This is basically an activity of daily living. So the assistive unlicensed personnel are actually the ideal person to perform this duty, but they really can't be required unless it's in their job description. So that's something that sometimes schools have to work on. So working on toilet training requires a team, and the family definitely needs to be involved, but the whole school staff needs to be involved as well. So some of the research I did showed that most children achieve control before school entrance, but up to 12% ages 6 to 12 and 1 to 3% 15 to 19 experience daytime incontinence. And then in one study, it showed that half of the students with autism show resistance to training and do have their accidents for sure. So if there's no disability that is known about, you do need to consider evaluation after you've ruled out any medical reasons. And of course, like I said, it's important to get buy-in from the parents. Otherwise, a plan is not going to work if you're just doing it at school and they're not following through at home for sure. So parents are generally responsible for supplies like clothes, diapers, training pants, and consider onchopresis when appropriate, when that might be, especially if they have an autism label. And refer for evaluation by a specialist if that's something that you are considering. And then, as always, abuse or neglect need to be considered in some situations, unfortunately. So some policy pearls, like I mentioned before, the nursing license is not required for tests associated with toileting. And due to the demands of providing healthcare for all students, nurses are usually quite limited in this area on a regular basis, but can help develop plans for training or help with evaluation that might be suggested. So as always, use of positive reinforcement and neutral supportive environment is often really helpful. Any staff that's involved with providing work in this area should have their hepatitis B vaccine for sure. And as always, student independence should be encouraged as much as able. So whatever they can do in the process to be independent is always very helpful and desirable, of course. So this presentation is based on resources I found in the IDOE Moodle. I know we didn't talk about it at our last, during the last session, but this is what the school nurse community looks like basically. And you can always either contact me or contact Jolene to find to get but it's on the website as well, the DOE Health Services website, how to sign up for a Moodle account. But there's just a plethora of, this is just a screenshot of part of the page of the Moodle. And if you look, toileting is under special services, which is really close to the bottom. It's very nicely organized, alphabetically ordered, in terms of the topics. I know that Sherry Coffey, who some of you may still know, worked on getting this organized, and is organized beautifully, I think, right now. But this is the area that I looked at, was toileting. And then if you click on the toileting link, it brings up these documents. So these are the policies that and procedures that we were able to find, and Jolene has listed as resources for you. There's some really good information I found in this the state of Washington guidelines. I really liked what they had put out in their guidance for this. And then this is actually from Greenfield Schools, I believe. So that's not the one I wanted. It's an example of their policy, and it talks about staff involved and having the hepatitis B vaccine, checking the diaper throughout the day. I mean, it basically outlines what the assisted licensed personnel is responsible for. So now I'd like to introduce Teresa Layton. She's the nurse manager at Riverview Westfield Washington Schools. She's also our school nurse administrator of the year, which we're very proud to announce. And she's going to talk to us a little bit about what their policy and procedures are. So are you on, Teresa, hopefully? There she is.
I am. Can you guys hear me okay? Okay.
Yep.
So I work with Westfield Washington Schools. Mainly I was coordinator and then worked with Riverview Health now, but I do coordinate with the school nurses. And we've had we don't have a policy per se at Westfield, but we do have standard operating procedures. And so we created documentation and ways to gather information on the students. I don't know, Deb, are you able to share those, or do you want me to?
I thought you can't see it.
I can't. I don't know if somebody else.
Maybe
No.
Maybe I need to stop. Let's see. Sorry.
That's okay. So basically the forms are just information that you would gather from the parents. So when we have the students that we're working with, to get like a good idea on what is going on, we always do like a 1-week evaluation. So we look at what's going on, how often it's going on, what time is the kid having issues, is there anything that drives it? Are they involved with recess, don't want to come in? Do they have a shy bladder? All those things we kind of take into consideration. And this, what Deb is showing, is a care plan that we kind of created. And this is just like basic template one that my nurses have used. And it just kind of goes through like what are some actions. It doesn't tell the nursing diagnosis. We actually use another form for that to do the diagnosis, but this kind of gives you some things to think about on what you would consider. The biggest thing that we do is if the student has IAs, if there's special needs, the district does now hire IAs that know that diapering is going to be part of it, or assisting toilet training is going to be part of the job. So we have less pushback when they know that from the start. And the school really has bought into that with us. The nurse's role is kind of figuring out scheduling when the student should sit. We only give them like 5 to 10 minutes. We don't want to go more than 10 minutes because sometimes they're not really engaged in the toileting process. Or if it goes too long, they're doing other things besides focusing on it. So the nurses will work with that, work with the teachers, like they get a sticker chart for sitting, they get a sticker chart for going, they get a little sticker that they add for washing hands. So just kind of incentives the whole way. And at the end of the week, they can turn in their little sticker form and they get a treasure trove, or they can look at other things too. So this what you're looking at right now is the assessment form we use. So we look at bowel assessment, and this is what we use just to talk to the parents, to just kind of assess what's going on. And that gives us an idea of what kind of stool they have. There's like daytime bladder, what's going on at home, nighttime bladder, what's going on at home. So if they haven't been evaluated by a physician, this kind of helps point us in the direction if we need to. And then we're always good at making an IHP for the student and doing just like certain goals we want to meet by hopefully get them trained for 2 weeks, be consistent. And then from there, we can reevaluate and see if we need to change anything up, or hopefully the student will be successful at that point. So, and then this one that Deb's showing right now, this comes from, we actually use the templates quite a bit from School Nursing 101, because you can go in and select the template that you need. Once we upload this in, we use Google Drive a lot. Once you make it a Google document, you can actually manipulate the document and then save it. So it gives us kind of like common nursing diagnoses, nursing interventions, assessments, and everything's kind of pre-planned. And I just actually picked everything there was. I know Deb has done a talk in the past on IHPs and told us to narrow it down to what you can really evaluate. Don't do everything in the world, but this just gives you an example of some of the options that are in there. So that's kind of how we do it in Westfield, and we've actually been pretty successful with them. We did have to put in exclusion criteria for some students who were losing bladder and bowel because the parents weren't being very good with us, like having the kids go home or wearing a pull-up or clothing that would allow leakage until things were taken care of. So we had an exclusion that if they can't contain the bladder and the bowel, over several times they had to be picked up from school, or we needed to look at other accommodations. So that was kind of unfortunate to include that, but it did help press the issue and protected the other kids in the environment so they didn't have an exposure. So
thank you, Teresa.
You're
Yeah.
welcome.
Yeah, no, that's great. I mean, it's great to have some tools to at least get started with, I think. And I know it's not a fun topic to talk about, but unfortunately, it's dominated almost every nursing conversation I've been involved in the last couple of years. And I don't know if it was the pandemic or what it is, but just seems like it's worse than I remember in the past. So it's good to have a starting place anyway. So I'll stop sharing.
Thank you, Deb. I agree. It's popped up a couple of different times, so I really appreciate that this community that you stepped up and brought someone in. Thank you, Deb and Teresa, for sharing so much. All right, we have one more topic before we get into our breakout rooms, where you're going to be able to have an opportunity to just dialogue with people regionally. And I'll walk you through what that looks like if you've never joined a breakout room before on Zoom. But before we do that, I want to bring our school health liaisons just up to the screen to kind of hide. I know some of them are on the call. We want to introduce them, let them tell a little bit about who they are and where they serve, so that if you've not met your school health liaison, you kind of can put a name with a face. So I know Ruthie and Jessica are going to kind of lead us through this little piece. So Ruthie, Jessica, take it away.
Yeah, it's just me today, Cindy. Ruthie's actually out of the office, so
Oh,
it's just
no worries.
myself.
Great.
Yeah, no problem though. I'm Jess Pinyard. I'm the Central Region School Health Liaison. And we just wanted to come on. Cindy had invited us today, and she had invited the local school health liaisons to come on. This is an excellent professional development opportunity. So glad that she extended that opportunity to them. But I cover the central region of the state, and I'll show the map here in a moment. But I work at the state level to support our 30 of our 95 local health departments, their school health liaison work. So the majority or most of the 95 local health departments do have a designated school health liaison. Not all, unfortunately, but most do. And I do know there's some on the call, and I don't want to put anybody on the spot who doesn't want to, but if there's anybody who's willing to come off from the local health departments and just share their name, what county they're with, and just, maybe drop their contact info in the chat. I kind of counted there's about 10 here. So we'll just give it a moment to see if anybody feels comfortable doing that. And while they do that, I'm going to pull up the map so you can see the central, where the central region is in the north and the south.
I'll get us started. My name is Amanda Bowling, and I am a school health liaison with Marion County. I was a high school nurse for 5 years prior to switching over to Marion County.
Wonderful. Thank you, Amanda, for being brave and leading the charge.
Hi, my name is Hope, and I'm the school health liaison for St. Joseph County, and that is the area of South Bend, Granger, Mishawaka, and Osceola.
Hi, I'm Sherry Stouffer. I'm in Clark County down in the southern part of the state, and I work alongside of Nola Garrison and Kathy Wood. We each have a set of schools that we're the main contact person for.
Thank you, Sherry.
I am Nola Garrison. I'm her counterpart.
Anyone else? I'll give it a moment, but
Hi. Hannah Mayberry with the Floyd County Health Department.
Wonderful. Thank you, Hannah.
Jessica, could I share something?
Yeah, of course, Sherry.
Noel and I are getting ready to have a nurses meeting for our Clark County nurses in April, and this is the 4th year we've done it. And we always try to have a couple speakers on a topic of interest. We've had an optometrist come and give vision screening tips. We've had Pfizer rep, etc. This year, NOLA had the idea to send out a questionnaire to see what topics would interest the nurses, and mental health was the top return. And so we really appreciate what we've heard on this, and gave us some tools and ideas of things we can share with the school nurses.
Cool. Thanks, Sherry, for sharing that. All right, if there's not anybody else, I just wanted to share on this map that I shared. We do have a new Southern Region School Health Liaison. She just started last month. So we don't have her picture on here yet, but her name is Mallory Swartzentruber. And again, this is our breakdown from the state level. There's 3 regional school health liaisons that then support the local health departments as they support you in your work in student health. So as Kelly White said earlier, if you don't already, either know who your school health liaison is or have a contact at the local health department that helps support you, I really encourage you to reach out to your local health department or connect with one of us in the regions, and we can help connect you with who your school health contact would be at your local health department. So again, want to thank Cindy for inviting us and for letting us take a moment to introduce ourselves.
Yeah, happy to do it. Really appreciate all the support that we know you provide. All right, so we are at 11:20, and that means that we have some time for you to connect regionally. And if you're in person, obviously it's kind of easy to connect. If you're on the Zoom and joining the Zoom, I'm going to give you an opportunity to join the regional space of your region. And here's, if you're not really sure which Zoom room to be in, they will pop up here in a minute when I open up the option, and you'll have actually 8 different options depending on the region. And I'll go through them here just so you're familiar with that. And the purpose of our meeting regionally is just to talk about, like, if something bubbled up this morning that you want to just debrief with the group, if you have a burning question that you believe regional people can ask and answer for you. Our health liaisons will probably be joining in their regional Zoom room, so you may be able to connect with them. It's just an opportunity to kind of meet and greet people in your space close to you, right? So the first breakout room is Southern Indiana Educational Service Center. So that would be these counties in gray. So if you're in one of those gray counties, even if you join, you're going to be joining that room. The Wilson Education Center is this maroon one that I'm circling right now. So if you're kind of down here in the southern eastern part of Indiana, that is the room you'd be in. West Central is just kind of west of Indianapolis all the way to the Illinois line. So you've got some options there. East Central is number 4 here. So again, to the east part of all the way down to the Ohio line. Wabash Valley is the next one. And the Wabash Valley facilitator could not attend. So if somebody wants to join that meeting in the Wabash Valley and kind of be the note taker for what's discussed, that would be great. Because another piece of this is that we have a facilitator in each of these rooms, and they're just taking notes about the topics that are coming up and the needs that are coming out, because then we'll use that information to determine what we're going to talk about the next time we meet up. So Wabash Valley is the next one. Then after Wabash Valley, we're going to combine Northern and Northwestern. So both of those are going to be in one. It's going to be called NW and Northern Indiana Education Center. When you get that option up, that's one. So 6 and 7 combined. Region 8, that's me up here. So if you're in one of these counties, you'll join the Region 8 Zoom room or breakout room. And then 9 is Central Indiana. And it's not necessarily just Marion County. If you joined via the CIESC information, you can join that. Their territory actually spills out into some of the border counties around Marion as well. So you kind of have an option which service center area you would like to join. So again, the purpose of our time, and it's going to be about 15 minutes, and then I'll bring everybody back together just for a final thank you and wishing us all well and all the things. It's just to connect again with people in your area, have some conversations. There'll be someone in there kind of facilitating and taking notes of some of the topics that have come up. And if you're not sure where to go, just don't choose something and then I can assign you if you're not totally sure. So I'm going to open the rooms now, and it should pop up on your screen, the choices, and you just choose your option and we'll get you going. So enjoy your time.